My screen.
Good evening, everyone. This is Stephanie Coleman with Kansas Lend. Thank you for joining us this evening. We are going to be talking about healthcare, transitioning healthcare for young adults. We know personally that we're going to hear a couple of personal stories, but we know that this is an extremely important topic that isn't getting enough screen time or whatever you want to talk about it, because I know from calls that I get from families that everybody is looking for an adult physician for their young adult with autism or other developmental disabilities, neurodevelopmental disabilities. So tonight we are going to hear from Dr. Zhang about healthcare transition, some of her research that she did in the rural and urban areas. And then we are going to hear about some things that are happening at the University of Kansas Medical Center through a little bit of research and a little bit of quality assurance. That will be from myself, Stephanie Coleman, Sydney Walls, who is our graduate research assistant, and then we'll also have Dr. Kelsie Kelly from family medicine at the University of Kansas Medical Center joining us as well. So just want to let you know, if you are on the Zoom and your video is on, your camera is on, when the slides are down, you will be on Facebook, because we are Facebook Live tonight and we are recording this. So other than that, we're going to get started and I'll turn it over to Dr. Zhang.
Thank you, Stephanie, for the introduction. Yes, I totally agree with Stephanie about healthcare transition. Definitely is a very important issue that we need to talk about, but has not been discussed enough. And I am a faculty member of the Department of Occupational Therapy Education. And then this research is to really look at healthcare transition for adolescents and young adults from rural and urban areas. And I do want to acknowledge that this project is supported by the Autism Intervention Research Network on Physical Health. I also want to acknowledge my team members for their contribution, particularly for Spencer Hanley as my community co-investigator. Also just want to acknowledge my mentors. So before I start talking about the research, I do want to kind of explain some of the abbreviations that I'm going to be using throughout the presentation. So first is adolescent or young adults, which stands for AYA, which is AYA. And also HCT stands for healthcare transition, HCP, healthcare professional, ASD, autism spectrum disorder, and RUCA, rural urban commuting area codes. I'm going to be explaining them a little bit more as I talk about them. So healthcare transition, so when we talk about it, we, like Stephanie's example there, is that parents are thinking about, oh, they want to find a adult physicians for their transition age child, and then all for young adults. So that is part of transition, meaning that you might be seeing a pediatrician at one point, but now you are thinking about you need to find a doctor that sees people across lifespan, all focusing on more adult population. So of course, healthcare transition, that's one form of healthcare transition. But healthcare transition does not necessarily always involve changing of physicians or doctors, because it could be that you are seeing a family physician as a young person, and then as you are growing and aging, you continue to see the family physician, but the healthcare transition still needs to happen where you need to have more self-management of your healthcare, learning how to have conversations with your doctors and asking questions in your appointments, and also taking charge of your own healthcare. So there are many things that's involved in healthcare transition, and healthcare transition does not necessarily involve changing of doctors and the physician or physicians or other providers. And just like any other types of transition, like education transition or employment and all those transitions, it's really a process that involves many steps, and it can happen for, it can be a process last quite a long time. So it's not one thing and then be done with it, and the people continue to learn about those healthcare transition skills and being more independent in their own healthcare. So everyone's journey is going to be a little bit different. So I do want to talk a little bit about, since I'm working, my primary focus is look at rural population. So the way I define rural is based on the U.S. Department of Agriculture. They have this system called RUCA. Basically, they determine your zip code and assign them to a code from 1 to 10. And then the higher or the larger the number is, meaning that the area is more rural. In general, RUCA code 1 to 3 are considered as urban areas. And then any numbers that are equal to 4 or larger than 4 is considered as rural areas. And I think this is a super fun thing to figure out whether you are rural or urban. So if you're interested in figuring out whether you are rural or urban, you can just, Google, am I rural? And then you might be able to find this ruralhealthinformation.org. And then you can just put in your zip code, and you will know whether what RUCA code you will be assigned. So that's about the rural parts. And then the reason why I really want to learn about rural is that there are a lot of the research to show that autistic AYAs, again, adolescents and young adults with autism, they are in rural areas, they in general experience higher healthcare disparities and also worse health outcomes compared to their urban counterparts. There are a lot of research having shown that. And in the meantime, there's really not, or maybe none, research that has really focused on healthcare transition for autistic AYAs, especially those in rural communities. As we all know that there's also research to show that successful healthcare transition actually lead to improved health outcomes and more knowledge of healthcare, and also insurance retention. And in the current stage of healthcare in the United States, insurance is super important related to health outcomes. So my research is really to kind of just trying to draw a picture or kind of get a sense of what it is like for AYAs living in rural area to start their healthcare transition, what their experience is like, including what their healthcare experiences are like, so that we can figure out ways to better support them. Maybe it's the training for families and AYAs, maybe it's the training for providers, maybe it's larger issues than just training. So, but we need to know what it looks like before we can do anything. So I used the mixed methods research. Basically, I used some questionnaire and also trying to interview people. So I used some questionnaire, really just trying to identify what people's experiences are, whether they have started a healthcare transition, what are the skills they are working on, whether they have insurance, what their healthcare experiences are like with the different providers. And all those questionnaires are guided, the development of those questionnaires are guided by my advisory board. So the advisory board is a really important part of my research to make sure that the research that the questions that I'm asking, or the way that I ask them, are relevant and making sense to the population that I'm trying to reach. So my advisory board included physicians, young adults with autism, parents, and then also parents from rural communities as well. As I already mentioned, that this advisory board has been very, very informative and helpful in making sure that we use plain language and making sure the questions we are asking actually is meaningful. So in terms of recruitment, this is originally this study was planned to be a study that's done in Kansas and the neighboring state, Missouri. But because of the recruitment challenge, I ended up having to reach out to this foundation, Simmons Foundation, and they have this Simmons Powering Autism Research, or SPARC. And then this is a research database. Basically, they enroll a lot of the families and individuals with autism and trying to support research by connecting researchers with families. So I have benefited greatly from this foundation. So I would highly recommend, if you are interested in providing research and support, maybe go look it up, and then you can join this network to be part of this research effort. So I'm going to talk really quickly about the results section. So again, I'm trying to look at the data for the participants that I have right now. So because this is an ongoing research, so I'm still collecting data. But so far, I have collected 82 rural participant data from 82 rural participants and 43 from urban participants. And they are all aged between the age 14 to 25, so adolescents to young adults, kind of covering some of the people who maybe just get at their starting age to think about transition, and also those who may have experienced those transition experiences as well. So for this survey, there are a lot of questions, I have to admit. So this survey can be completed either by the AYA themselves. They can also complete with the support of whoever they want to identify as the caregiver to complete the survey with them, or they can have someone complete the survey on behalf of them, and we were able to capture how they were able to complete the survey. But in general, we have a pretty comparable sample between rural and urban, and we definitely also see some diversity here as well of this participant pool. And then again, we have almost similar age and like average age of our participants between rural and urban. We also asked them about their independence level. So this is something that's totally self-rated. So whether they are mostly independent or maybe they are more dependent on others. And then in general, those two groups are, there's no difference in how independent they are. So very similar level of independence. We also asked questions about their communication modality. So we understand that there's a lot of differences in how people communicate within the autism community. So we asked whether they use verbal, sign language, pictures, or other type of electronic devices for communication. And this is just to kind of add, is that this is a multiple choices are allowed. So you can be using verbal, but also using other modalities of communication. So so it's still quite similar in terms of between rural and urban participants, and with majority of the participants being verbal for both groups.
Alice, can I just cut in here and just make a comment or
Yes.
question? Like, I am very surprised, I guess, that these are so similar, the rural and
Yeah.
urbans, that, you know, you don't think about it. Like, I mean, in my mind, I always know that the rural areas don't have access to a lot of the things that we have here in the metro area, but you didn't realize that they really needed it just as much. And by these numbers, you can tell, like, sign language, using electronic devices, that's really, wow. So that's interesting to see and exciting to see too. I mean, to get to know that.
Yeah, great observation. I totally agree with you. So this is just kind of the sample and then their demographics, but also just kind of going kind of like spoiler alert a little bit, is that I really, in terms of the healthcare experiences and the healthcare transition, at least based on my sample, there are more similarities than differences as well. So
this is great information for the state organizations to have, to say, okay, we need to put some additional refunding and resources into electronic devices in the rural areas, or letting them know that they're options. So, okay, thank you.
Yeah, thank you for the comment. Yeah, another thing is, because I don't remember whether we have said that, so I'm gonna have to jump off the meeting once I'm done with my presentation. So if anyone on the presentation have questions, please feel free to ask during the meeting, and you can feel free to unmute yourself, or you can just put it in the chat, and Stephanie, she will be kindly helping me to monitor the chat. Okay, so this is a question asking about what type of providers they are currently seeing. So for the, which is, you know, there's also not a significant differences in terms of the providers they are seeing. So of course, that's most of them are actually seeing primary care physicians. The rural participants do have, like, 61% of them are seeing primary care physicians versus about 46 of them are seeing primary care physicians in the urban community. So which is very, very similar. And then, and also some of the things that are not very encouraging is that there is about 7% of the rural participants and 16% of the urban participants have not seen a provider, you know, in the last year, which is a little bit concerning. So those are the data there. And then we also asked some questions related to how they utilize healthcare services and what type of help they would need to support their healthcare experiences. So we asked them whether they need help coordinating healthcare services. And then the orange bar represents urban population, and the rural bar is represented by the blue. Rural population is represented by the blue bar here. So again, there are some differences, but interestingly, that 48, almost 49% of the people in the urban community that they need help coordinating healthcare services, versus about 38% of the people who said they need help in rural communities. But nevertheless, there, you know, there are still a great number of people, no matter whether they are from rural or urban, saying that they need help, especially the 48.8%. That's a large number. That's almost half of. Do you have a comment?
No, I do, but go ahead and finish that statement.
Yeah, I just want to say that that's very, very concerning. Half of the urban population, AYAs with autism, thinks that they need help coordinating healthcare services, all meaning that they are not having enough support currently. Yeah, go
ahead. So my comment was going to be, like, in rural areas, you know, they have that family physician from birth on, so they probably just feel like they're going to continue on with that physician. whether they have, I mean, yes, the physician knows that child or young adult now, but they may not have been trained on IDD, where in the metro areas, most individuals do see a pediatrician and then go looking for an adult physician later versus having that family physician. So I'm wondering if that's kind of like where that difference is.
That's a really, really good point. I can totally see that. Or maybe there are more like specialists being seen in the urban areas, and then there's a need for that coordination.
Right.
So because kind of, I'm going to hold that thought about the specialist, because that's something that's identified later as a really significant barrier. Okay, it's right here, so I don't have to hold that thought very long. So this is another graph. I understand there are a lot of numbers and probably a little bit hard to read, but I will kind of talk through this graph to kind of help us get the gist of this graph. So again, the urban still is represented by the orange bar, and the rural is represented by the blue bar. And then, so basically we listed several barriers to healthcare and ask people to kind of identify them. Again, people can choose multiple answers through this question. And then, so the higher the higher number the people chose this question, then it's going to be towards the bottom of this. So this is how it goes. So the biggest barrier that's identified by the rural population is actually limited providers, including specialists, which is not surprising, right? Because that's something that we have been hearing from the research and other data source, that there are declining providers in the rural community, particularly specialists. So that is something that is more urgent in the rural community. But there are also some barriers that are pretty, similarly experienced by rural and urban participants. So for example, hard to find the providers that are right for me. That was chose by 42% of the urban population and by 46% of the rural population. So that's, finding that right providers, not just any providers, maybe the providers that understand the communication preference and all the provide individualized services. Those things are really, really a struggle for both rural and urban participants. And another thing that's quite interesting is the length of travel time. So for rural participants, is 39% of the people chose this one, and 35% of the urban participants chose this one as a barrier as well. So, which is very, very interesting, because in the past, all the research has been saying that for rural communities, traveling is one of the top barriers, but it still remains as a very significant barrier. But I wasn't expecting that in urban communities, that traveling time is also considered one of the top barriers. Okay, to kind of summarize this is that in terms of the barriers, there are many barriers that are common for these two populations, and the only difference is that the limited providers, including specialists, really is rated as the #1 barrier for rural population, and it didn't make it into the urban top 3. So kind of really emphasize that or reinforce that message that we have been hearing all these years about the lack of providers in rural communities. I know that it's already 6:25, so I'm gonna speed up a little bit. So another question we did ask participants is that whether your providers have discussed the healthcare transition with you. And then we ask, of course, they can answer yes or no, or maybe they're not sure. So for the rural participants, we have 72% of the people who said no, no one. So this provider is not like, your physician, your primary physician or your pediatrician. It's any healthcare provider. And then this number is even bigger for urban participants. 79% of the urban participants said that no providers have ever discussed the healthcare transition with them, which is very, very concerning. So my conclusion about this is just that, the difference between urban and rural, there's really no difference between rural and urban in this particular question. It's just that they're equally bad. Like kind of going back to what we said earlier about really there's a lot of lack of focus on healthcare transition and having that conversation. Okay, so this is another question we asked, kind of, align with that healthcare transition, and knowing that healthcare transition, a big part of it is insurance, figuring out the healthcare cost and being able to navigate all the systems, and also learning those things can help, help people maintain their insurance coverage and things like that. So we asked this question about whether you have had any discussions about insurance coverage with your providers. And then again, significant numbers of people from both rural and urban areas are saying no. They have never had this kind of conversation with their providers.
And Alice, what would the insurance question, why would it be important?
Why would it be important?
Having that conversation with young adults. So
so part of the healthcare transition is really, figuring out from very, very like small things about like making the appointment and then knowing what doctor you should be seeing, to asking questions, but also figuring out what insurance you should be on, and also how to navigate the insurance when like understanding that what is covered and what is not covered, and all those things, or whether you can be on your parents' insurance or maybe you can be on Medicaid. All those type of things are very, very important, because I definitely have heard from young adults where they're saying that they don't have insurance because they're not eligible to be on their parents' insurance anymore, but they are also not on any, like Medicaid or anything else. So they're not even seeking medical care because they don't have insurance. So I think part of that, it can be contributed to the fact that there's really not a conversation that is happening with healthcare providers or family members, or maybe not enough conversation about that kind of, gonna have very serious health impact on the people who do not have that figured out. Does that answer your question? Or
no, that's great. I just want to make sure that families understand why their young adults need to have this conversation as well. So thanks.
Yeah,
appreciate
absolutely. That. And this is a very, very tricky thing. I felt like insurance is so complicated. As a 30-some-year adult who have like, have a higher education, I'm still so confused about health insurance, and very confused when I talk to the health insurance representatives on the phone. So I think, so sometimes it's natural for people to not think about it too much, and then just to say, I will take care of it for my child, or things like that. But there's at some point that they need to learn as much as they can to kind of have more control on that.
Right, because us parents are not always going to be around. So yes, most definitely.
Yes,
thanks.
Absolutely.
Okay.
So anyway, so kind of the discussion that I want to have here is really quickly that, again, this is an ongoing study. We will try to get more responses, but I felt like it's probably not going to change the fact that the major conclusion is that healthcare transition or healthcare experiences are equally bad for adolescents and young adults with autism in rural and urban communities. I don't think that's going to change that big picture. And of course, this really shows that both rural and urban autistic AYAs, they really need more support and need more from different levels, from individual level, but also from the system level, to help them and making sure that they have the support to have that transition. And I'm going to skip this. I'm going to plug my recruitment advertisement here a little bit. Is that I'm continuing to recruit urban participants, and also I'm also conducting interviews with autistic adolescents and young adults as well. So trying to understand, like, you know, making sense of the data, the numbers, right? We want to have more like stories behind those numbers. So I'm continuing to recruit, and if here's my flyer. So if we have this survey that if there's an AYA who's between the ages of 14 to 25, we would be able to complete this survey with a $20 gift card as an appreciation. And we're currently really recruiting urban participants. So if you are interested in participating, please, maybe, I don't know what's the best way to do this, but maybe just, I will put my email address in the chat later, and please feel free to email me, or just email Stephanie. She will definitely forward you.
Absolutely.
Connect you with me. And also we are also interviewing urban AYAs as well. And so if anyone who's between the 14 and 25 age range, let us know as well. And also we are also recruiting physicians. And so if you know, like, for example, if you know a physician who has experience working with individuals with autism and between the ages of 14 to 25, or maybe your child has a physician who is, you know, having experience, and please let them know that I'm also recruiting as well. So I think that's my research, and I do want to share some resources here. So there's a great website called goutransition.org, and they have some wonderful resources, and for physicians, for families, for AYAs themselves. But I do have to mention that this website is designed for just anyone with pediatric population. So it's not designed or geared towards individuals with autism or other developmental disabilities. But they do have this one called a special population resource. I'm not a fan of this word special population, but they do have some resources that are more tailored to individuals with developmental disabilities as well. They have some really nice checklists to let you know what are the skills you need to practice and figure out while you are working on the transition.
Great.
Okay. Yeah. So this is my the research email address. So please feel free to email me, and also, again, please feel free to email Stephanie to connect with me.
Well, thank you, Alice. We appreciate learning a little bit of your research. Hearing that information, it just lets families know what they need to really prepare for too. I know before I started in this career, I wasn't a big fan of research either. I know that it's a good thing, but you know, I'm not all that details, but it really is important for families to understand that the research that's being done is going to help our kiddos, young and young adults and older, and through the lifespan. So I really want to encourage the people who are watching this to really reach out, whether it's Alice's research or somebody else asks you to do research. Really consider doing that research, because there was a lot of people that came before us that did research, and thanks to them, our kiddos were given the supports and resources that they learned from that research before. So, you know, it's like, we got to thank them, but we got to keep moving it forward. So please consider doing that. Your future friends and family will thank you for that. So, all right.
That's so well said. And thank you, Stephanie, for being on my advisory board and helping with a lot of the things as well, contributing with your unique perspective. So you are contributing to research. Thank you.
Yes. All right. Well, thanks, Alice.
If there's a question, I'm going to jump off the meeting. And
No,
if anyone has any questions for me, please feel free to email me as well. Oh.
Yeah, I do not see any questions, so we will let you go. And I appreciate it. There were several people out watching this on Facebook, so getting the information out there.
Yeah, sounds good. Bye-bye.
Bye. All right, up next, we have some additional information from Sydney Walls, myself, and Dr. Kelly will share in some areas when she feels it's appropriate. So hello, Dr. Kelly.
Hello, sorry for my delay. Just got back from choir concert, so.
I hope it was wonderful and it's perfect timing, so no worries there at all. We just got done with Alice's research, so perfect timing. So now we're going to talk about what the University of Kansas Medical Center has been doing towards getting IDD inclusion across the campus. So thanks, Sydney, for getting this together. And I'm going to start out by sharing our story and why this is so important to me and why I am doing what I'm doing now. So this is Matthew Zhang. If you've ever been on one of our trainings before, you may have heard me talk about him or may have even seen a picture of him. But Matthew Zhang is 27 years old. He was diagnosed with ADHD at 2.5 and then received an autism spectrum disorder diagnosis at the age of 13. So it was a pretty late diagnosis. And to me, I knew nothing. You know, when somebody said, had he ever been evaluated for autism before, I was just starstruck. I had no idea what they were talking about. But we did end up going and getting that diagnosis. He has since also received a Tourette's diagnosis. And from a school writing perspective, he has dysgraphia as well. So it's been pretty interesting, but we have made it through. He just graduated college in December of last year. Yeah, so it was a pretty cool celebration. We just actually celebrated it a couple of weeks ago, the coldest day in Kansas of April, but that's all right. So you'll see here that he graduated. He has a bachelor's degree in communications from a university in Arkansas that is very inclusive. It's a very small private university. It's called the University of the Ozarks. And I would encourage families to check into it if you are looking for a college that can appropriately support your child around executive functioning opportunities. So, but to move on, Matthew has been at KU Pediatrics since we moved to Kansas about he's 27, so about 21 years ago. And, you know, his pediatrician, Dr. Nelson, she would always tell me, you know, it's time to start looking. I'm like, yeah, I know, but I can't find anybody. So she had told me that she would keep seeing him until he graduated from college. But the year before, or year and a half before, I ended up seeing a resident in family medicine at KU. And I asked her, would she be willing to see Matthew? And she just jumped on board. Absolutely. She was very excited about the opportunity. So I said, great. And then I went back to one of my mentors, Dr. Kathy Ellerbeck, and reached out to Dr. Kelsie Kelly from family medicine and asked them, what can we do? What can we do to prepare residents to support intellectual and developmental disabilities within family medicine? They knew, Dr. Kelly knew she was already seeing some of those individuals, but we really wanted to prepare the residents as well. So whether they stay at KU or they go somewhere else, they are prepared to support our young adult when they transition, or just children through the lifespan as well, if they're in a small rural area and in a family practice. So I was really excited. We got together and we were able to work with some additional residents within family medicine, and Sydney Walls and some others came on, and we have some information to share shortly about that. But I want to let you know, if you are watching this and you are looking in the Kansas City area or willing to drive to Kansas City area, KU is still a great place to go. Especially, I know there's a lot of kids with intellectual and developmental disabilities who are like, KU, I don't want to go anywhere but KU, because they like that Jayhawk, they like this basketball team, they like the football team, or whatever, or maybe it's just the Jayhawk. So now they don't have to, right? They know that they can go to family medicine and be supported. So with that, I'm going to turn it over to Sydney. Like I said, she's going to share some information, not just what we've done with family residents, but with some School of Medicine too. It is quite surprising, but a lot of medical schools don't necessarily teach on intellectual and developmental disabilities. So you'll hear some more about that. Sydney?
Thank you. Before I get into that, I wanted to also share my story. I have a brother who's 15 months younger than me, who's diagnosed with autism, intellectual disability. He's non-speaking, and he is under the 24/7 care of my parents, even to this day. And when he was 22, I'm sure a lot of you have experienced this, he aged out of pediatric care, and we couldn't find anyone to take care of him. So we were just like, screw it, we're going to go without a physician. And then when he turned 24, he started having very severe medical and behavioral issues. And we desperately needed someone to take care of him. It took a full year to find someone. We kept getting rejected to our face, ignored by dozens of clinicians who just said, I don't feel comfortable. I don't know enough about your brother's condition. And it was very disheartening. And eventually we found a perfect clinician who we love and who did help us very quickly. And we're so very lucky to have found someone. But as Stephanie said, the root of this issue, I want to be so angry at these clinicians, right? I want to be so angry, but it's not their fault. It's not their fault that there is this issue, that they're not given the tools and the education to help folks like my brother Zach, like Matthew, because they're just not given. As Stephanie just said, it is not a requirement at almost all medical schools to teach about developmental medicine. It is not a requirement in the least. There is a lot of development, especially at KU Med, which I'll get into improving this education, because ultimately that is the root of why so many physicians decline, and any clinician decline having patients like my brother, like Matthew. And so one of the things that we're doing at KU Med before we get into the residency education is we're trying to tackle it early in the medical students and medical education. So right now we're doing a project where we're trying to develop a pilot curriculum for medical students to learn about IDD. And with this, we're trying not only to improve their knowledge, but also to instill altruistic and improved perceptions of IDD that are more than just they're a patient and I need to fix them. And so I'd also like to shout out the leader of this project who couldn't be here today. Her name's Dr. Lenny Swales. She's a developmental psychologist at KU Med, and she's absolutely wonderful, has literally dedicated years of her career trying to get this started, and has many, many dreams for the future of this project. But what this project really starts with is that there's two wonderful organizations, national organizations. One of them is the American Academy of Developmental Medicine and Dentistry, and then the other, which I'm sure all of you have heard of, is Special Olympics. And they came together and they were like, this is a huge deficit. We need to educate medical students on this important topic. So what they developed is the National Curriculum Initiative of Developmental Medicine. And what we're trying to do at KU is implement that. They came up with a fantastic curriculum, and we want to make sure our medical students are getting that. So what this curriculum looks like, as we modified it so we can do it for our medical students, so it's a little different than what Special Olympics developed, but same things. It's a 3-part course. The first part are 6 online webinars that the students take anytime they want over the semester. It involves a stakeholder panel, which was a live session where we had 6 folks from the IDD community come in and answer questions that the students had and talk about other various things. And then the final component was a case study discussion where we had clinicians who work specifically with this field go through some case studies and explain what is the best route of care. And so these are some of the topics of the webinars. You can look through them. I won't list all of them, but ultimately it's how do we care for different types of folks with disability? What is the system of care? And what is consent, guardianship, supported decision-making? Where do we go on from there, from making medical decisions? I explained a little bit of the stakeholder panel already, but the people that we had came from Special Olympics, Kansas City League of Autistics, UMKC's Institute of Human Development. We had someone from KU Lawrence come in who has an IDD, and then I also was a panelist from the family perspective. And then I won't get into the specifics of the case study discussion, but these were the types of patients that we talked about. 18-year-old who had, issues with sexuality and consent, different referral issues, and then the impact of family-centered care with someone who's newly diagnosed with a disability. So we don't have the results from this project yet. We're actually the students are still taking the course right now. But some information that I thought was really important to share from their pre-survey. So before they even took the course, we had them fill out some surveys about what are your thoughts on IDD? What are your thoughts on X, Y, and Z in regards to IDD? And what we found was some interesting things. So looking in the perception of IDD, when the students were asked to rate their opinion, either disagree or agree on the following statement, the majority of doctors lack knowledge regarding caring for people with IDD. The vast majority of the students agreed. And whenever we asked them the same question, but with the following statement, people with IDD have more difficulty in accessing healthcare as compared to the general population. Again, almost complete agreement that that is an issue. And to me, this reads as they're so aware that this is a problem. They are totally aware. It's not that it's this underground issue. They're completely in full attention that there is an issue here, and they wanted to improve that. They acknowledge that they're needing to take initiative. But there are also some misconceptions of IDD, and there's more than just the couple I described here, but same style of question, but with the following statement: people with IDD can accurately describe their health systems. There's a lot of variation where the majority disagreed. And that, as we know, can be a pretty dangerous misconception to have, especially with adults and people who have IDD and are not under guardianship, have complete medical, power of control of their medical decisions and not being believed by their physicians. That can be a very dangerous belief to have from a clinician point of view. And another statement was, people with IDD should always be accompanied by a caregiver during medical appointments. There's a perfect bell curve here. There's a lot of confusion of, do we need caregivers, yes or no? And of course, it's situational. It depends on the patient, but there was no consensus on whether someone needs a caregiver or not, completely dependent on their disability status. So the future of this program is, of course, to improve this course. But we want to make it an elective at KU Med that third year and fourth year medical students can choose to learn about this course, and then ultimately make it a requirement. As I mentioned before, hardly any medical schools have this as a requirement. So if KU Med can be one of those pioneers in this, that could start a huge wave of change for other Midwest public medical schools. So getting on to the family medicine residency education, in which both Stephanie and Dr. Kelly were a part of, it's a similar thing. We wanted to create an educational module for future family medicine residents about IDD healthcare across the lifespan. So not just pediatric, because family medicine works more with across the lifespan. We wanted to make sure that we're also helping those adults. And what we did is there was a 3-part lecture series that was over the span of, and please correct me, of 3 or 4 months. And we covered things from legal concerns and ADA, resources for individuals with IDD and for families. And also, we also had a case study discussion with the residents on different varying patients and what would the best route of care be. And these were led by Dr. Kelly, who's present here, Stephanie, and then Stephanie already mentioned Dr. Kathy Ellerbeck and another resident who helped us. And what we wanted to do is see, does this improve opinions, outlooks, perceptions, and knowledge on IDD for the residents? And you don't need to look at the numbers right now, but ultimately we surveyed before and after the residents on different topics. And we asked them to rate their comfort from a scale of 0 to 100, 0 being not comfortable at all, and 100 being the most comfortable you can be. And these were the 5 most improved topics. So it went from a span of 24 points. So I believe the average was about a 26, so pretty low on the spectrum. And then it moved to 50. So more people were very comfortable with this. And the top 5 topics were IEPs and 504 plans, discussing sexual health, comfortable using different communication devices, that transition to adulthood, which is such an important topic. And then the 5th most improved one was confidence in treating individuals with various gender identities. And as I go through this, every single topic improved. Every single thing that we surveyed them on improved at least by 3 points, which may not be significant, but it is for us. Like the fact that 100% of everything looked better than before is improvement in anyone's eyes. And another thing I thought was also notable of improvement is we asked the residents before whether they believe disability is an aspect of diversity or identity, or if disability is an impairment that needs to be fixed. And before we gave them the course, it was about a 45. So more people were in between, not sure. And then that went down. More and more people were believing that disability is this aspect of diversity and cultural identity, which arguably could be one of the most important beliefs to have for a physician when you're treating someone with IDD, because that is not something to be fixed. It is something to accommodate, to learn how to live with and thrive from that point on. And so the future of this program is to cycle, rinse, repeat with this, have it every 18 months, because that is a full cycle for the residency program is 18 months. And that should hopefully reach every single resident in that program. But also the purpose of this is to expand to other departments, OBGYN, internal medicine,
Sydney,
neurology. Yeah.
Sydney, I just want to interrupt you because I think you said that resident was 18 months.
Oh, was it? Oh, what is it?
I'm Dr. Kelly.
So residency is 3 years. We chose to do an 18-month cycle. That way we'd hopefully hit them ideally twice with the different topics, but if not, at least once. So that's why it's an 18-month cycle.
So I just wanted to clarify that it's 3 years, not 18 months. So
Yeah. Hopefully they see the lecture series twice in their 3 years, because a lot of these residents work night shifts and morning shifts, and those on night shifts don't get the lecture series, unfortunately. So the idea is to tackle every resident across the spectrum of their 3 years, and then hopefully expand to more and more departments. And it just, again, with the medical school project, this is just improving the idea and our definition of inclusion at KU Med, which is ever improving. And this is just a perfect example of that.
yeah, I want to thank Dr. Kelly for being a champion for us. I know this is an area that she has studied in the past and worked with Dr. Ellerbeck quite a bit on. So she was our easy get champion in family medicine. And I do want to move forward and go into different departments such as internal medicine and others, because there is not one single specialty in any field of medical that will not see people with intellectual and developmental disabilities. So want to get that done.
I think
And
something I tell a lot of people is there's this misconception that we need more specialists, which we always do, but we need more generalists to know about IDD because, as you just said, everyone works with IDD patients, regardless.
regardless of your specialty. Yeah.
Thank you for the presentation, Sydney, and Stephanie for sharing the importance of the work that you all are doing. And I think it's really important that we start in the pipeline early on. So medical school is really important. I'm happy that that's happening. And I would just say that, education, the didactics and everything, we are really hoping to create an inclusive environment within our clinic as well. That's a work in progress. And thanks for input from families and patients. We're working to improve that and make, again, our clinic more of an inclusive environment for those with intellectual and developmental disabilities. It's important, like you both said, right? Like, it doesn't matter who you are, what kind of doctor you are, what kind of healthcare provider you are, you're going to interact with someone who has an intellectual or developmental disability, and it's important to provide them that full spectrum or whole care. They're no different than the rest of us. They deserve just as much, if not more. So I don't have much more wisdom to add. We actually had 4 workshops, not 3.
Oh.
I led a workshop on healthcare transitions and provided tools and resources to bridge the gap, as well as because there's that lack of confidence on, like, how do I care for someone with autism? Is there something special I need to be thinking about? What if there's behavior issues? How do I work through that? And provided some resources to our residents and how to access those, and if they happen to have a patient and need to work through some things with families. So
that's fantastic. I'll also encourage people, if you are, whether you're in a pediatrics office, your pediatrician's office, or anybody's office, if they ask if they can bring in medical students or residents, if you're comfortable with it, please do that, because that's another way for them to learn hands-on. Whenever we go and, go to an appointment and someone asks, and Matthew's like, sure, more the merrier. And then he finds out they're all women and he gets really excited, all these beautiful women in a small room with him. So, but they're learning, and that's the important piece. Hands-on learning is what they're going to learn better than any lecture or any webinar. So please consider that. So I don't know if anybody has any questions. I'm looking out on Facebook. I don't see any questions out there. Is there any questions here? If not, it's okay. If you have any questions, if you're watching this, once it's archived on YouTube, if you have any questions about the research that Dr. Zhang shared, any of the research or the quality assurance projects that Sydney and I shared about, and Dr. Kelly's work, feel free to reach out. You can always start by coming to kansasland@kumc.edu, and we can make sure you're shared to the right person, forwarded to the right person. So I want to thank everybody. I want to thank Dr. Kelly for hopping on here after that choir concert. I hope it was a wonderful concert. Thank you, Sydney, for always having such great work. Sydney is one of our favorite research assistants I think we've ever had in the LEND program. She is amazing. So I want to shout out to her and thank her for that as well. And we'll look forward to next month, which is, it'll be on healthy lifestyle. So we'll look forward to you joining us next month, and everybody have a great evening.